Okay, so can everyone see what we got here?
Yes.
Okay, and pull up the chat window so that you guys can talk to us. Okay, so tonight we're going to talk about pre-hospital consent. And I actually thought that this is going to be a lot longer of a talk than it's turned out to be, and that's okay. I'd like for this to be something where we have some dialogue, especially at the end. I've got three cases to present to you, and they're cases where it's these are difficult areas to talk about. And so, I do want you, if you come up with a question or something, um, you know, um, I want you to go ahead and, yeah, I'll try to see if I can, I'll see if I can lock the room. Um, um, there we go. Okay. So, um, just if you have a question or something, put it on the chat or unlock your microphone and let's talk about it. So, yes, this is going to be somewhat long and complicated. It's gray areas. There, oftentimes these are very emotional situations, and there's some landmines that can really get you in trouble if you're not careful. And the one thing that I have to drill into people is this is not just what we think about these things. This has to come from an area where we're trying to educate our patient and allow them to make that judgment call. And people are permitted to make bad decisions. It happens. And the only thing is it cannot be a decision that hurts somebody else. And errors here can result in lawsuits or even criminal charges. So I'm going to tell you, this is kind of my principle about this. Now, Ridley, this is in a textbook here. Maximization of respect for the patient autonomy and bodily integrity rather than the imposition of the doctor's professional's values. So, this is what informed consent is all about. Now, let me boil it down to something that I find easier to do, and that is I'm not here to tell anybody else how to live their life. My job as an emergency physician is just simply to assist others in making informed decisions. And if they know it's a bad decision, that's informed. And they bear the responsibility. The classic thing that I say when I'm taking the history from somebody is, do you smoke? And they say, yes. You realize that that's not a good thing. And they're like, yeah, okay, well, that's your choice. You've made that decision. You know that it's not good. That's an informed decision. And I'll tell them exactly what I just quoted you, what's in the red there. So, just kind of keep that in mind. We're not here to impose our will on anybody else. We are simply here to help them make the best decision for their health care possible at that particular time. So, informed consent has several components to it: competency, capacity, and while capacity seems pretty straightforward, we're going to spend a little bit of time on that one. And these are some of the things that we have to document. They have sufficient information about their condition. They understand the risk and the benefits, okay, including doing nothing, and the ability to use that information in keeping with their own personal values. And they can communicate their choices, and they haven't had undue influence from others. So, competency. Is this person their own medical decision maker? Okay, sounds pretty straightforward. It's a legally defined term. So this is something that we don't decide. We don't look at somebody and say they have competency or not. This is for a judge or a letter of the law to say. So parents, guardians, law enforcement, custody, those are legally defined. There are exceptions where even minors can make their own decisions. And in these cases, we have to do what that child requests, even over parental objections. Okay. Can somebody think of one area where a child saying, I want you to do this would take precedent? You can unmute your mic.
Any life
Pregnancy.
measures?
Pregnancy. What was the other one?
Life-saving
Emancipated.
measures.
Yeah. So those are some exceptions. Some adults may be judged in a court to be incompetent. Okay. Once again, that's a judge saying this. So this is a legal definition. Dementia. However, just be careful, because there are a lot of people out there that have papers that are drawn up that grants power of attorney to somebody when somebody is unable to make those decisions. Just because somebody has a diagnosis of dementia does not mean that they're at that state. So we have to be very careful in those situations. Cognitive impairment. So, not just dementia, there's other reasons for cognitive impairment. But once again, these are court ordered things, and they have what's called a surrogate decision maker, an SDM. And you'll see that again in a minute. Now, if the surrogate is not available, if they're not around, you really need to always err on the side of transporting for a medical screening evaluation to whatever facility that you would go to. And that sometimes can present some issues in itself. But just be aware that when courts have already stepped in and made that decision, we have to follow that. So, general consent. We're not going to spend a lot of time on this, but this was where I work right now has a great poster that I really like that talks about consent, and that's where these flow charts have come from. But everyone has the autonomy or the right to refuse or accept care. There are some regulations, there are ethical considerations, and then of course you need to keep in mind sometimes you don't have to have consent. Those are immediate life threats and also things for suspected abuse. So in those situations, you don't have to have consent. Now, this is a busy slide, and I apologize for it. I wish that there was some way that I could put this so that it would be easier to see and still make it one column. But this is for an incapacitated adult. So this is somebody that the courts have said they cannot make their decisions anymore. So if there is a designated surrogate, then you should do that, or whoever has durable power of attorney is the other term for this. And then there's a spouse, adult child, or an adult child with a waiver from the others, or a majority of the children available. Patient's parents. You don't think about that very often with an incapacitated adult unless you're dealing with somebody that has MRDD or one of those other cognitive impairments. It may be implied because of immediate life threat or other clearly identified person. So there's a lot of these things, but you need to also keep in mind that there are some things where they cannot give consent. We're talking about inpatient mental health, ECT treatment, or appointing another SDM. And Murph, good question. This is actually state of Texas. So if you're in another state, please check with your service and check with the laws in your state, because there are some variations on this, and we'll kind of cover some of that in a little bit, especially when it comes to mental health reasons. So good question. I'm sorry, I should have brought that up earlier. So consent for minors. Okay, once again, this is in Texas. We have the parents, and this is a Catholic hospital that I work for, and they separate out the natural and legitimate from adoptive. So being an adopted kid and also being one that has adopted kids, to me, they're all the same. At that point, the natural parents' ties have been severed by the court. So they are, even though they're adoptive, they're considered the same as natural parents. Sole managing conservator is a very rare sort of thing that you're not going to see very often. And if you do, they're going to have a court order. The possessory conservator is somebody that is a conservator that has custody of that child for that time, but it's not a permanent sort of thing. And I had to look some of these things up as well because, frankly, in 38 years of EMS and medicine, I've never seen it. Grandparents, adult siblings, and so forth. And then the other one that is interesting is the court or peace officer of the Texas Youth Commission. Um, and so just keep in mind that we didn't really come up with it earlier, but somebody that's in the custody of the police have that ability. So back up here, um, the incapacitated legally, that what we're talking about there is we're talking, once again, we're talking about a court order. That is a competency question. So, or a capacity question, sorry. So this is the, if they're incapacitated legally, that's what we're talking about. Those are the ones that have the surrogate decision makers. Um, and actually, if there is a conservator, answering Kyle's question, if there is a conservator that has been appointed by the court, yes, they do supersede grandparents. Usually, even in that case, the parents' rights have been cut off as well. So, that's it's one of those things where there's going to be court orders that will be there. Legitimate parent, that's a good question. What we're talking about there is probably a parent that is on the birth certificate, but not necessarily in the child's life. Um, the police dropping charges. Well, yeah, if they bring them there and they're no longer in their custody, then the if the patient has no other reason to not have their ability to make their decisions, in other words, they're happy and healthy otherwise, and but they didn't want to come in, and now they have their that capacity back from the police, then no, you can't treat them. So, and to me, that's along the lines of, okay, you can either go with them or you can go with us. And so, it, that's a very touchy subject in a lot of places, and I understand both sides of that particular argument, and actually, we will talk about that to some extent. So, how about a minor? When can they consent for their own care? The biggest one is an active duty military member. Okay. And so you can enlist in the military at age 17 in the United States. And so if you are an active duty military member, then you have the right to consent for your own treatment. Emancipated minors is the other one that we see a lot. But if a teenager is pregnant, or if they're presenting for a reportable condition, or if it's their own child, so even if a 16-year-old comes in with their own child for care, that is the parent. She can consent to care. And as you see down there, if they have the capacity to give consent for their own children, they can consent for their own care. So, it's one of those, you grew up awful fast. And then if they're seeking counseling for abuse, suicide, or chemical dependency, they can consent for their own care there as well. So, capacity. Capacity is not a permanent thing. It goes beyond alert and oriented, but if they are not alert and oriented, they don't have capacity. Okay. If they're homicidal, suicidal, or psychotic, they don't have capacity. And head injuries with the GCS less than 12 also. Now, the interesting one is an intoxicated person. Now, the problem is judging intoxication. That is a very, very tricky sort of thing. And so, I have known some people that are walking around with blood alcohols in the 300 to 400 range, and we're talking at that point 8 times the legal limits, or 4 times the legal limit at some point. And these people are, you hate to use this term, but sober as a judge. You know, they walk, they talk, they, make sense. They're not slurring their words. Are they intoxicated? That's hard to say. So it is reasonable to have law enforcement help you out with these sort of things. And so I would urge you, if somebody's intoxicated and they're saying that they don't want to come, it would probably be a good idea to get law enforcement on the scene if possible. And now this is from medical oversight. This is the textbook for EMS medical directors. And so if you have any questions, then you should always try to err on the side of the patient's best interest. But remember, the capacity as opposed to competence, which is legal. So capacity is something that is fluid and that can change. So you need to keep that in mind. Any questions up to this point? So competency is a judge telling somebody. Capacity is your evaluation of the patient. Clear as mud? Okay. So one of those other points is that you have to give the patient sufficient information about their condition. So you need to let them know what you think it is and why EMS is probably not the right way to rule that in or out. You need to give them the risk and benefits of the treatment and transport and all alternatives, including doing nothing. And you got to use a language that the patient can understand. Okay. This is not the time to try to impress people with the big words such as myocardial infarction or myocardial ischemia. You got to explain it to them in words that they can understand. Analogies work great, but you cannot attempt to influence their choice. And then they have to understand these risks and benefits. So this is a time when you need to sit down and say, okay, I've talked to you about all this stuff, and I just want to be sure that you understand what we're talking about. Can you tell me what I told you in your own words? Tell me what you understand that I just told you. And it takes a long time to do these. It really does. And then what you really want to know is that they are able to use this information. So you need to ask them to explain their decision to you and the reasoning behind it. It tells you an awful lot about their mental status. It tells you that they have listened to you. It tells you that they have insight into what's going on, and they have some mental reasoning on why they're wanting to refuse care. And they also are showing that they can communicate with you. And this is really important. You need to focus on how the decision was made, not the outcome. Okay. When people choose to not do what we recommend, that is not a failure on our part. It's not a failure on their part. It is just what is happening, and we just have to get over it and not take it as some kind of insult to us. Can they communicate their choices? Okay. Can you tell how they came to that decision? Okay. Can they tell you if there's anything that they didn't understand? This is the time for us to say, okay, I know that you heard that I don't think that you're having a heart attack. What I really need to tell you is that it doesn't look like it right now, but that doesn't completely mean that you're not. Something to that effect. There's many situations, obviously, that could be used for this. And then this is a really important one: freedom to act without undue influence from others, including family and friends. So, Byron, let's see. Any tips on handling? Okay. Well, language barriers, these are a difficult sort of thing any way that we cut it. There should be, through your agency, a language line that you can access to be able to get to some of those things. I don't know how many of y'all have iPhones, but iPhone just put out on their newest version translate. So there's the icon down at the bottom there. And it can actually do verbal translation from, they can take what somebody says, translate it into English, and then take English and translate it back into that language verbally. So there are several different things. There's another app that is out there. It's from the National Institutes of Health called Canopy. Canopy is an interesting product because I actually got the opportunity to meet um, a ULIS fire officer from ULIS, Texas, that developed this app before there were apps. And it's an interesting process that he went through to get to that. I'm not going to take up time here with this, but he came to me and he said, take a look at this, see what you think. He said, I broke the rule. He said, we are always told, don't ask yes, no questions. Just ask, the open-ended questions. He said, you can't do that with this. So he said, just about every question is a yes, no question. And Canopy is in probably 30 languages. So, most of them, they have to read it. So if they're only able to speak their language and they can't read it, it doesn't help, but it is an option. I see Google Translate there. I like Google as well. And yes, short sentences definitely are better. Frankly, from a medical perspective, I would recommend Canopy first. And if you're interested in learning a language, Canopy also has some language lessons in there. And I believe that that's probably the link for it that Byron just gave us. So here's a big thing. We have a responsibility to these people, but not to try to sway them. Okay. It's not our decision to make. And they do have the right to make decisions that may lead to their own harm. Okay. This is a very good quote. Once again, this is from Medical Oversight of EMS. Is there a question? Okay. Patients have the right to make medical treatment decisions that may result in deterioration and even death. If you have ever met Anne Majori, she is a fantastic speaker. She is a paramedic, but also an attorney. I believe she's in New Mexico the last time that I heard. If you go to a conference or get a chance to hear one of her talks, go to it. Yeah, she is a very impressive lady and very well read. And then here's my principle again. Okay, I'm not here to tell anyone how to live. My job is to assist them in making informed decisions. And if they know it's a bad decision, that's informed, that's on them. So let's talk about some other factors, DNRs. Okay, first off, you got to confirm that they're valid before withholding resuscitation. Okay, there are times that they may have been rescinded. There may also be some very specific plans in there. So, especially depending on state to state, hang on just a second. Some states have some very special rules. Most recently, I've been working in Ohio, and Ohio actually has two levels of DNR. They have DNR CC and DNR CCA. The difference is CC is comfort care. Those people are comfort care then from the time that they sign that DNR CC order. They are just simply comfort care. You just make them comfortable. You don't treat anything else. Okay. CCA, on the other hand, is do not resuscitate at the time of arrest. You just make them comfortable during that time. So in other words, you don't do any treatment of anything with a CC. Okay. I had some nurses that kind of got upset at me because I had a little lady up there from a nursing home, had fallen, had bilateral subdural hematomas. She was a DNRCC. And I talked to the family and I told them, listen, here's the deal. This is a quality of life matter. certainly nobody's going to start CPR or anything, but we really need to take her from this freestanding ER, which we were at a freestanding ER, and send her to a trauma center so that they can see if there's anything that does have to be done, once again, for her quality of life. And so, it's a touchy area in some places. When I was in Missouri, we actually had at the hospital there like 5 different levels of resuscitation, full resuscitation to all the way down to check on them every shift and see if they still have a pulse, basically. But there was, chemical code. There was an intubation only. There was no intubation, no CPR, cardioversion, or defibrillation. Defibrillation. I mean, there was this Chinese menu of options. So wherever you're at, just be sure that before you withhold everything, that you're doing exactly what the patient wants. And then, once again, from medical oversight, when doubt regarding a DNR request is there, you should go ahead and proceed under the principle of beneficence and proceed with full treatment. So in other words, err on the side of doing everything. Nobody has ever been successfully sued for wrongful life. There have been suits for wrongful death. So I know that sounds harsh, but as a medical director, I would much rather that you err on the side of doing too much if there is any question about it. Start resuscitation and call the medical director. That's always a good option. So, just err on the side of doing the right thing for the patient. Now, power of attorney. Okay, we kind of touched on this a little bit, and this is to identify a decision maker when no one else is able. There, in most states, it's a legal POA and a medical POA, or what's called a durable power of attorney for medical care. So you need to see the paperwork to decide which one you're dealing with. And if there is none, then you got to talk about those things that we talked about earlier, if they're incapacitated and unable to make decisions. If the power of attorney is there and you know that that's who it is and it's in the paperwork and they're refusing care, you need to do all the same stuff. Talk to them about what's going on. Talk to them about all the possible complications and things that could happen, and then find out, their rationale for refusal and those sort of things. You're not trying to strong arm them. And in these situations, I will tell the family, listen, I'm just telling you this because I have to. It's the right way to do this. And so I want you to make the best decision as you know this patient, because I don't know them. So Murphy, you got a question there. Let me pull the chat screen over. Well, first off, if they're asking me to put a pillow over their face, that's malfeasance. If they're simply saying, he fell, he hit his head, he doesn't want to, he did not want to have things like CT scans and all this other stuff. He's not bleeding, and so we're going to leave him here. I don't think that that's malfeasance. If you think that there is something like that, I think it's reasonable to call police and say, okay, you just come and talk to them, and it's more a matter of, when I talk to these folks, the way that I word it is, I don't know this patient, you do, or somebody else does. And so I want to be sure that I'm not doing anything that they would not want me to do. And there are, and I agree, Murph, there are times when it may feel like you should do more than you're being allowed. I get that. And so if you really feel that it's, something where it's, hate to say it this way, but evil, then at that point you need to go ahead and get law enforcement involved and talk to the medical director, online medical control, whoever that is. And that'll be coming up in this as well. Living wills. These are very, very broad in scope, and most of them are very vague, most of the ones that I've read. And the only binding part most of the time is that they want you to have two physicians that agree that the patient is brain dead before removing them from life support. Most of the time, it doesn't have the specifics that we need on the emergency medicine side. And in fact, I'll take you back to would have been the year 2000. My parents came up to visit us in Missouri, and when they came, they brought with them their wills and living wills and those sort of things. And I started going through this with my dad, and I'm like, Dad, I need to know some other information. And he was like, okay, well, what's that? And I said, okay, if your heart stops beating and you stop breathing, what do you want us to do? That's not in here. And he was like, what do you mean? And, my dad was a wholesale hardware salesman. He was not medical. Mom was not medical. So started explaining some of these things, and they both got very upset and ended up walking out on me. And, those are some hard conversations to have with people. But at the time of a cardiac arrest is not the time to try to interpret that document. So if one of your parents brings you something like this, it's a hard conversation, but you do need to have that conversation with people. And I have it in the ER with them all the time. So conclusion, it's often easier to transport, but you have an obligation to care for and respect the patient's right to self-determination. You need to try to reach an outcome that's agreeable to everyone. And Murph, that's obviously the thing that bugged you guys, is it wasn't necessarily agreeable to everyone. I don't know the exact situation. And once again, sometimes this may be that you call their doctor for an office visit. You may say, okay, well, if you're not going to go with us, can we at least help you get in the car so that they can take you? Or there may be something else that you can arrange. If you're in a system where there's community paramedicine, maybe you can arrange to have the community paramedic come out and visit with them and check on them. Frankly, I think that is probably one of the places where community paramedicine is going to be able to shine as it develops. Remember that the patients can refuse care as long as they understand their situation, they understand the risk and the benefits that they are assuming, and that reason is less important than the process used to make the decision. And they can make bad choices if they understand that it's not the best decision. And if it's complicated, like you're alluding to, Murph, get online medical direction involved. I do not hesitate at all telling my crews to call law enforcement, get the sheriff out there, because I don't want to take away somebody's rights. Okay. Now, here's another big one. We should never be offended by these things. It's their right to choose. And as has been said by wiser people than me, you pay your money, you make your choice. Okay. But I always, when somebody refuses my care, my plan, I always tell them, okay, you know what? If you change your mind, come back. Or in the case of EMS, please call us back. We want to come back. We want to help you. We want to do the right thing for you. And nobody is going to be upset or say, I told you so. We just want to care for you. And the reason that I put that last part in there about nobody being upset, I did have a patient one time that came back like 3 days after I'd seen them. And I said, if you changed your mind, why'd you wait so long? And they said, well, I was afraid that you'd be mad at me. I'm like, no, I'm not mad. I'm happy that you're here. I just wish that you'd been here sooner so that we could have taken care of this quicker. So, keep in mind that people have a lot of things that affect their decision making. And there are a lot of factors that we will never know that goes into their rationale for why they're making that decision. Even if you go through and you ask them all of those questions, they'll come up with answers, but it may not be the full answer. So before we go on to that, let me see everyone here, and let's see anybody with questions. So Joe, you've been awful quiet tonight. Are you still there? How about Justin? That's fine. Is anybody still there? Y'all have any questions?
Can we go back to consent when it comes to law enforcement?
When it comes to law enforcement, what's the question?
Over here in the state of New Mexico, if we have a patient,
Mm-hmm.
let's say law enforcement calls us out to somebody who got tased, just for an example. That person, they don't lose their rights to treatment. They consent. They are able to say, I don't want EMS working on me, even though they might be tased, they might need a probe removed. They can say, do not touch me, and we have to respect that.
Hmm.
What is that over in Texas? How would you interpret that as a medical director?
Well, frankly, in Texas, if somebody is in police custody, okay, now there's a difference between somebody that is arrested and somebody that is detained. A detained person retains all their rights, but a person under arrest does not. And I suspect that that's really probably what you're talking about in New Mexico as well. But you would need to talk to an attorney like for your agency to clarify some of that. But in Texas, and frankly in Ohio and Missouri was the same way. If the person is simply detained, they have their rights. But if they are under arrest, then the police can order you to do medical procedures to a certain point. They're not going to tell you to cut off a leg or something like that, obviously, but they do not, once they're in police custody and arrested, they no longer have those rights. And so it's one of those, it's kind of an area that it sounds like is variable from state to state, but frankly that's the first time that I've heard that, if it's truly for everyone, including an arrested individual. So then I guess my question would be, how does that pertain to, say, an inmate at a correctional center? If you got called to the jail for somebody that is in jail, for a misdemeanor and they're there for 90 days and they've been convicted already, and the jailer law enforcement official said that you needed to take care of them and they said don't touch me, how would,
The,
do you know how?
the way I understand it, sir, even someone who is in full custody, they are arrested, they are incarcerated, they are allowed to refuse treatment for themselves, even if an official says that they have to. They literally, the law enforcement officer sometimes here has to go to court, assuming the person having a heart attack or having a myocardial infarction, and they're going to up and die in the next 20 minutes of code.
Wow.
Sometimes you do have to go to court to get a court order to say, yes, this person is allowed to be treated. People, I don't understand it, but it has happened.
Hey, yeah, where politicians are involved, I've given up on trying to understand most of those things because there is no understanding politics. Um, so I hats off to you guys for having to deal with that. I'm sorry, but this is one of those where the caveat of you know being sure that you're doing what is the letter of the law in your state has to prevail, and there's no way that I could know what that is in any state other than the one that I work into. And yeah, I'll leave that compassionate release. The other one that I see quite often, when I was in Ohio, was that they would fill out a paper that said that this person is no longer in custody, but if you discharge them from the hospital, you need to call us because we have a warrant for their arrest. It's like, okay. Yeah, and in Texas, Justin, the same thing. Yeah, if that happens, a lot of times they'll just the law enforcement officer will take them to the hospital here too. Um, but usually it's the ones that I hate are okay, you can either go with them to the hospital or you go with us to jail. Yeah. And then of course they get to us and get to the hospital and they're like, I don't want anything, and they want to leave. And then
Can
it
we
turns into a question of, can they?
can we talk about that for just a second?
Absolutely.
Okay, so if a law enforcement officer, if we witness that, if they say you can either go with us to jail or you can go with them to the hospital, what is the level of objection that we should raise to that?
It's not
Technically,
the
at that
time for
point,
you to do it there.
it's assault. Technically, at that point, it's assault. They are being threatened with physical confinement.
Well, it would be false imprisonment, but that's what I would tell you is that on the side of the road at 3 a.m. is not the time to settle that situation. That's when
Yes,
you need to get the leadership from your service involved, and they need to talk with the police leadership and let them know that that isn't the right thing to do, and why. Um, and certainly, I think that those are questions where, there's this would be a great time if Gene Gandy were still alive, because him being an attorney and having been a state's attorney as well as a defense attorney, he would certainly know this a lot better than I ever will. But yeah, and it is sad that I think, just from looking at the chat here, you can see that most of us have dealt with this at some point in our career. I know I have many times. So, anything else at this point? You want to go through a couple of the cases here? So, case one. I'm going to move the chat window so that you can see this. 78-year-old male who's a farmer. His daughter noticed him holding his chest and sweating, and she says he's been a long time smoker and high blood pressure, and you notice that he's diaphoretic and rubbing his chest, and he's speaking in 3 to 4 word sentences, and he allows you to get vital signs and EKG. Normal sinus rhythm rate is 83, but there's 1 millimeter ST elevation in lead 2 and AVF, and no other significant changes. So, anyone want to call that a STEMI?
Yes.
Why is it a STEMI?
no, I don't think it is a STEMI.
No. The criteria is 2 millimeters ST elevation in 2 or more contiguous leads, with or without reciprocal changes, with the exception of, there is an exception, B1 and B2, if you have 1 millimeter ST depression, that may be a posterior MI. So this is not a STEMI, okay? So
I haven't gotten to
then,
my, sorry.
that's okay. No, that's fine. I would much rather that you speak up and let's go ahead and discuss it rather than us not discussing it. It clears it up, and that way you've got another point of reference for when you get to that. So don't worry about that. Here are the vitals. Heart rate's 83, respiration's 22, 128/72, O2 sat is 92% on room air. So some of y'all may not have been here when we've talked about spit and skid. Let's talk about 4 items. So, and yeah, I think that this probably is potentially a non-STEMI cardiac event, but we'll come back to that in a minute. So, can somebody give me a serious diagnosis?
Emphysema exacerbation.
Okay. How about a probable diagnosis? What do you think it really is? I think the non-STEMI cardiac event is probably a good one, or acute coronary syndrome is another way of putting that. How about an
Stable
interesting
angina.
diagnosis? Huh?
Stable angina.
Well, we can talk about stable versus unstable. But let's go on to the interesting diagnosis. What would be a zebra?
With the presentation, I would say pulmonary embolism would be a zebra.
Absolutely. And then a treatable diagnosis. There's your There's your angina. So that's a good one for that. Do you think this guy is sick or not sick?
Sick.
Yeah, I think he's probably sick. Okay. So we talked about some of the killer diagnosis. Pulmonary embolism, you got to think about at least. It's not very likely. And there's an interesting lecture in itself on PEs and the EKG changes that you typically see with it. He does not have them, by the way. What else? We talked about angina. We talked about PE. What other things could kill this patient?
Could it be pulmonary hypertension?
Pulmonary hypertension, that's probably not something that you're going to see a presentation of very often. But yeah, you got to at least kind of consider that. That requires an ultrasound to make that diagnosis.
Some type of thoracic aneurysm.
Aneurysm, absolutely. What else? Oh, you're doing excellent on this. You really are. What about a pneumonia? So,
I was going to say pneumonia or COPD possibly.
Absolutely. Okay. So what do you want to do with this patient?
Hospital.
So tell me, well, okay, hospital, but let's get a little more coned down on it. You want an IV? Do you want O2? Do you want a monitor? You want aspirin? You know, those sort of things.
Monitor and O2.
Definitely, yeah.
Okay. And so your disposition would be transport to the hospital.
Yes.
Excellent. Those are the way that I want you to do the spit and skid. So what are you going to tell the patient?
I'm going to tell him that, sir, I think you're having a heart attack. You seem to be having symptoms that show that you're going to be having some serious issues. And if you don't go to the hospital, not only could you die, but you might not be able to get your harvest in.
Okay. Well, when you tell him that, he says, I've got hay that has to be baled before it rains. I can't go to the hospital. So Kyle, what are you going to say now?
Well, probably something along the lines of, if you don't allow us to take you to the hospital, it's very likely that you're not going to be baling any hay for any more harvests before any more rainstorms.
Okay. Tell you what, let's think about this more from the perspective of we're not trying to scare him into this. We want him to understand the gravity of the situation, and then we want to try to find out from him why he doesn't want to go other than this. So in my opinion, the way that I would approach this would be, okay, sir, I absolutely understand. The thing is, you may still be having a heart attack, but we can't tell that in an ambulance. There are some things that need to be done, some tests that need to be done that we can't do in an ambulance that have to be done at a hospital. Now, if you're not having a heart attack, they may get you out of here, in a couple of hours. But at the same time, if you are having a heart attack, you risk actually dying, or you could become a cripple to the point where you're not able to do what you were able to do before. You may have congestive heart failure. You may have trouble breathing for the rest of your life. You might not be able to climb up into the tractor to be able to bale the hay. Now, I know I'm telling you a bunch of stuff that's scary, and I don't mean to scare you. I just want you to understand what I'm really concerned about. So what I would like to do is I would like to start an IV, place you on this monitor, and take you to the hospital so that they can check all of these things. We also want to make sure it's not something as simple as a pneumonia. You may have a pneumonia, and that may be all that it is, and you need some antibiotics, and you can get back out here. Now, at that point, I want them to say, okay, let me tell you the risk and the benefits, okay? The risk is that, if you don't go, you could, obviously the worst cases, you could die, but you could also become a cardiac cripple. You could end up having some problems where you're not able to live the life that you want to live. You could have a bad infection that ends up worsening your lungs, so there are all these possibilities. And if you don't go, yeah, I got to admit, you may be fine, but I don't have the ability to tell you that. Then ask them to tell you back, explain to me the risk and benefits that I've explained to you, but in your own words. What do you understand that I told you? And that's where they need to be able to put all that stuff together to be able to explain to you what they understand about the situation. Okay. Then, okay, so I understand you're saying that you don't want to go, and you've explained back to me the risk and everything. Can you tell me what's the real reason that you don't want to go? And it's not my decision to make, it's yours to make. And let them explain that. And frankly, my experience has been most of the time when you explain it to them like that, they're able to explain that back to you, and they tend to go ahead and agree. Okay. um, Michael, excellent point. Who is in this situation right here? Michael, I'm going to pick on you. Who is the best witness for this?
I would say if the guy had a spouse or a kid or something, maybe a
Read the
neighbor,
case. Who called you?
his daughter. Yep, I'll give it the daughter.
Yeah, so a family member is always the best one. Okay. But you also have to document all of the stuff that you talked about. This is not a time for you to just do a checkbox and say that they signed an AMA form. Okay. First question, do you think that this guy has the capacity to refuse?
Indicates.
Yes.
Yeah, definitely. Do you think that he has the ability to understand his situation?
Yes.
Yes.
Yeah, I would say so. If he's able to tell you that he has to get out to start baling hay, and especially if it is going to start raining soon, I'd say that he's pretty with it. So, and we just talked about that. So let's talk about another case.
Quick question, if you don't mind, sir.
Yeah, absolutely.
This kind of differs off of consent, but I remember learning that you're not supposed to give nitroglycerin with right-sided heart failure because it decreases preload and afterload and all that stuff. But short of doing a right-sided EKG, which I'm not sure how to do, but short of doing that, when would you withhold giving nitro? Like, would it be worth it, withhold giving it for the potential detrimental effects to it? Like, is it better to give it or better not to give it if you're not sure?
Well, in this case, this guy is not having a STEMI. What we're talking about usually is an inferior wall MI. Okay, so if they have 2 or more millimeters ST elevation in 2-3 AVF and or reciprocal changes in the lateral lead, so B3 through 6, then those are the ones where it's not a matter of withholding the nitroglycerin as much as it is not giving it as early. You want to have an IV in place. And the reason for that is that right ventricle is a very floppy, thin-walled structure. And so it has a certain amount of tone on that all the time. But if you give nitroglycerin, suddenly it relaxes, and now it has more capacitance, and so it's not able to fill as well, and so then they drop their blood pressure. So the way that you diagnose it, if you're going to do right-sided leads, is that you put the V leads on the right side. So instead of being 1, 2, 3, 4, 5, 6, it's 1, 2, 3, 4, 5, 6. So it's that simple. But you can do the same thing just by looking at 2, 3, and AVF, because that's really the go-to is 2, 3, and AVF. Excellent question, though.
Thank you.
So you're called to see somebody that has collapsed, an 82-year-old. You find his son performing CPR on his father. The rescuer is providing good quality hands-only CPR and is not tiring at this point. As you prepare to assume care for the patient, first responders arrive to assist, and the lieutenant asks if the patient has a DNR, a living will. Son and the wife say that he has a living will, and has not had any serious medical conditions. And so the lieutenant takes a living will and starts to read it. Okay. And they just moved to Texas from, ironically, this is actually a real case. They moved from Missouri to Texas. So, and that was shortly after I had actually moved back to Texas from Missouri as well. So I know the way that the laws were in both states right about this time. So first off, spit and skid. Serious. So what is a serious diagnosis in this patient? So Byron, I appreciate you asking that. Cardiac arrest, absolutely. Okay. Although that kind of takes away your probable. Okay. But so a serious one could be a pulmonary embolism. Okay. So you may have a saddle embolus that has blocked off all blood flow. Probable is most likely a rhythmic cardiac arrest. So in other words, they had an arrhythmia and it was deteriorated into VFib and then asystole. What about an interesting or a zebra diagnosis? With cardiac arrest, there's not really a whole lot. Septic shock. Yeah, AAA is a good one. Septic shock. And then a treatable one, well, most cardiac arrests really are not that treatable other than if they're in VFib. So are they sick or not sick? This is a skid part. I would say he's sick. Anybody else? Okay. Killer diagnoses. Pretty much everything that we already described is your killer diagnoses, but depending on his rhythm, you may need to think about your H's and T's. Okay, so hyperkalemia, all those, the tamponade, we won't go through all of those things at this point. And then interventions, CPR is a good start. And then disposition, well, we'll see. It depends on your system. Just curious, how many of y'all are in a system right now where your medical director has you doing field pronouncements?
For us, it depends on how long the patient has been down at that point.
Okay, so let's say that you had a VFib arrest and you arrive on scene and somebody's doing CPR, and let's say you work them for 20 or 30 minutes and there's no change. Would that be something that y'all would pronounce or not?
Well, at that point, they would already be in the back of the ambulance, and we'd already be on the way to the hospital. Because our longest transport time that we have in my area is probably going to be about 20 minutes, I guess.
Okay.
So.
Okay. Well, the reason that I ask is that. Okay. Thank you, Shay. Thanks for letting us know. Hopefully you get to just watch and not do anything. We had a bull rider that got killed at a rodeo here just this last week in Mineral Wells. The reason that I ask is I have never understood the wisdom of transporting a body with red lights and siren. And so my service, we try not to transport dead people. So that's obviously your medical director's decision to make. It's not mine. But at the same time, I also don't want my crews getting injured. So anybody want to tell me, especially in your area, what exactly does a living will mean? And is it something that's really that important where you're at?
In New Mexico, it means nothing.
Okay. Okay. So the son is insisting that the patient should be resuscitated. The lieutenant, however, has called online medical control and they were told to cease efforts. So, like I said, this was actually a real world case. And I won't go into the particulars. However, the living will said that they had to have two physicians state that the patient was brain dead in order to terminate care and to remove like a ventilator and stuff. And so the lieutenant did the wrong thing. They actually had police restrain the son and stop resuscitation on his dad in this particular case. And I was at a meeting where the son actually was testifying before our committee, and it ended up there was some legislation that now says that in Texas you cannot expect a paramedic to interpret a living will. Now I think that's probably a good thing.
Sir, I've practiced in North Carolina, and I've practiced in Texas and New Mexico. And
Mm-hmm.
in the state of North Carolina, a living will is not valid in a pre-hospital environment. In the state of New Mexico, it's the exact same thing. In order to have living will, you have to be in what we call a clinical environment, i.e., 4 walls and a doctor.
Yeah, and I think that that's a wise move. But we're not here to discuss the politics of it. I just want you to understand the legalities of it. So, let me. So this one's a little bit different because this time you've got this single car rolled over. It's not the driver. He's 17. He was in the passenger seat. He has a hematoma and has a 4-centimeter scalp lac, and the bleeding has stopped. And the driver says that he was knocked out for a minute. And so there's his vital signs, stone cold normal. We'll skip over that. So he says that he's not going anywhere, but he'll let you dress his wound. Anyone got heartburn? Anyone think he can refuse?
So with the loss of consciousness, but I mean, as long as I think as he returns to baseline, technically he can still refuse, as far as I know.
He's 17.
Oh, yeah.
Most states he's not an adult.
At that point, him being 17, we'd have to contact a parent or a legal guardian and see what they would want to do.
Okay. At that point, he pulls out his military ID. He is active duty in the Army.
I was getting ready to say, what's his ID?
Yeah, you got to ask those questions. But yeah, and usually they're going to tell you that right up front if they're in that situation. The other area would be an emancipated minor. So, but those folks, and I've only run into a few of them, they are very upfront about, I have emancipation. I am not, a minor. Let's see. So you're called to check on a person walking on the side of the road in the middle of the day. It's a summer day. It's 110 outside. They're disheveled. He looks like he's about 25. He's in no acute distress. He says he doesn't need any help. And he is walking barefoot on the asphalt. He's refusing any care and assessment. He says, don't touch me. I don't want you here. I didn't call you. What do you do?
I'm not a law enforcement officer. There's not much I can do.
Okay. Anybody else?
I usually try to reason with them, tell them, no, we know that you didn't call us, but somebody did. We have to at least ask you some questions and get his ANO times 4, see if he has capacity. If he refuses or is just, it's a hard kind of case, then we get law enforcement out there.
Okay. And so, I'll tell you what I would probably approach this as is, hey, you know what? It's 110 degrees out here. How about if we just let you sit in the back here and cool off for a little bit, and we'll just chat for a little bit. I'm not taking you anywhere. In fact, my partner will come and sit back here with me, so nobody's in the driver's seat. Nobody's going to take off driving with you. I mean, to me, that's actually a reasonable sort of thing to do. Now, the next question is, do you like silver bracelets with short chains connecting them? Okay, because if you try to take this guy that's probably in your future. Okay. Placing an IV against his will is a tort of battery. Holding him is false imprisonment, and chemically or physically restraining him is battery and false imprisonment. So you have to do something to assess whether he has capacity or not. And so there's actually a great resource I found. I happened to find it. I've never found it until preparing for this lecture, and this is Stat Pearls. And this particular case and some of the stuff about capacity and consent came from Wes Ogilvy. And I don't know if any of y'all know who Wes is. Wes actually is an attorney for the state of Texas, not in DSHS or anything like that. But he is also a volunteer paramedic down in the Houston area. And so he is a good person to get to know. And he writes a lot of stuff on EMS and medicine or legal perspectives. So yeah, in his little article there that I've given you the link to is very well written. He's one of the authors. There's several of them. And so, yeah, I would definitely tell you to look at his stuff. Now, Justin, you have an excellent point there that law enforcement probably is not going to do a whole lot. This actually was a real case that I had as a paramedic. And thankfully, I was the one driving the ambulance that day. But this particular patient had been walking about 10 miles when he finally had somebody call 911. And thankfully, he was actually very reasonable. We said, yeah, come in, sit in for a while. How about if we take you somewhere where they can get you something to eat? Okay, well, that sounds good. So we took him to John Peter Smith in Fort Worth and took him upstairs. Well, my partner, as we're getting ready to leave, he said, I'll take him up to psych. You don't have to come up there. And I'm like, okay. So he came back down laughing. And I said, what are you laughing about? He said, when you get up to the psych floor, the elevator opens, you get out, the elevator closes, and then you're locked in this little ante room waiting for them to open the door. Yeah. He goes, the guy looks at me and he goes, Fred, I really enjoyed talking to you. Could I maybe get your phone number or something? That way, if I need to talk to someone, I can give you a call. And Fred goes, I'm sitting here going, oh my God, the hell am I going to tell this guy? And he goes, hold on. I know. If I need to talk to someone, I can just go and talk to the trees and you'll hear me. Excellent plan. And about that time, they opened the doors for him. So, humorous end to what could be something that is a bad outcome. But, so what questions do you guys have at this point?
First, since you mentioned the statement here, chemically or physically restraining him equates to the tort of false imprisonment and battery. Can we talk about Colorado and ketamine for a minute? That case that got all the play.
No, we can talk about it. I'll tell you right now, I don't know all of the particulars, so it'll be a little limited.
Well, my wife actually, so it's funny, that gentleman who was the one who was restrained and died, the guy who got the ketamine, she actually followed him on Instagram for years. He was a violin teacher and he was autistic. At that point, he was under police custody. They claimed that he was a danger to himself or others. It sounds from what happened that they kind of browbeat some paramedics into putting a dose of a sedative on board, and the paramedics went way too high on it. When it comes to this, when it comes to somebody who's a consent issue, what are your thoughts? Because I know there's probably not some legal basis you can just kind of pull out, but what are your thoughts on this?
Well, first off, once again, there are differences between laws from state to state. And so, I can't, that's one big reason why I can't really speak to the particulars there. In Texas, in those cases, the patient is being placed into protective custody and law enforcement can consent for those sort of things. Now, the other thing that I would tell you is that First off, ketamine is a very, very safe medication. I know that it's gotten some bad raps, but this is a drug that has been around since the 50s and 60s, and it is used as anesthesia in third world countries. And so it has a very good safety record. In fact, in one discussion about this when it was first becoming a very hot topic in the States, there was a presentation where they said that a child accidentally was given 10 times their regular dose. And the only thing different was that the child slept longer. And so it has a huge safety margin. Now, where you can end up with some issues is if you start manipulating the airway, you can cause a laryngospasm. So that is one problem. The other problem that you can have with it is that it can cause a lot of salivation. And so, it's not a drug where you're going to be able to just give them a shot and walk away and let the police take over. They're going to have to go to the hospital at that point. But it is for most patients a very safe drug. Now, just the same as, I told you what I'm dealing with right now. Well, you know what? For most people, what I'm dealing with personally myself is going to be a non-event. For most people, they're going to have minimal symptoms, and so far that's what I've had. But there's going to be outliers. And we can talk about that most people that die with that particular disease have a lot of other comorbidities, but then they're always going to point to one or two that didn't. And so it's the same thing with ketamine. Ketamine, for most people, is a very safe drug. It's been used many, many years. When I was a resident, my anesthesia rotation, I asked the anesthesiologist what drug would he recommend to sedate a child for procedures. Without hesitation, ketamine. And I'm like, then why don't we have ketamine in the ER? Well, because anesthesia won't let you have it. Your anesthesia, why won't you let us have it? Well, we got to have something that we can do. Yeah. But my point is, I've been using this drug since 1995. When I finished my residency, got into the Air Force, we had it in the ER. It is very safe. It has a huge safety margin associated with it. And so, there may have been some other things that we don't know about and probably will never know about in this particular case that led to his death. And I don't think just a simple overdose was really the whole thing with it. Of course, anesthesia people have come out and said that it should never be given in a pre-hospital setting and those sort of things. And the EMS physicians that reported that in an EMS physician group was, have they ever wrestled somebody? There are a lot of factors involved in these sort of decisions, and I don't think that I've ever dealt with a law enforcement officer that immediately thinks, oh, give them a shot of something. That in fact, that's way off of their continuum of force.
Yes,
is to drug somebody.
well, sir, would you, you've been a practicing paramedic, would there be a time where if law enforcement were to tell you, maybe less about consent, more about, separation of powers, but hey, we need you to give them something, how would you tell them that you didn't feel comfortable doing that or that it wasn't safe to do it?
Well, I think that the answer to that is that's not in my protocols. Unless you have a chemical restraint protocol, it's not in your protocols.
All right,
Most
sir.
services I've worked for have said that if a restraint is given to the patient, then he becomes your patient. He's no longer going to be under law enforcement custody. He's going to have to come on the ambulance with you, and then law enforcement
absolutely
can come with you and follow you and everything. But at that point, he becomes your patient and not, like I said, just strictly in their custody.
Yeah, and those are all things that have to be spelled out in the chemical restraint policy or protocol if you have one. But if you don't have one, then, hey, I'd love to help you, but that's you practicing medicine without a license, not you, but the police officer. So, the simplest way to handle that is either, okay, this is what my protocol says, this is what we got to do, or we don't have a protocol for this, I can't do it. Anything else? Well, guys, as always, I've enjoyed it. We'll talk again. I don't know when the next one that I'm scheduled for is, but once again, if y'all have any questions or anything that comes up, let me know. You can get a hold of me through email or any number of ways, and wish everyone the best. Have a good night.
Thank you, doctor. You too.
All right, sir.
All right. Thank you. Good night.